Right now, if you've ever had general anesthesia for a surgery, you know exactly how strange the experience actually is. One moment you're lying on a table, counting backward or chatting with a nurse. And then, seemingly instantly, you're waking up somewhere else entirely, hours later with absolutely no memory of anything in between. No dreams, no sense of time passing, nothing. It's not like sleep where you at least get some vague sense of a night having occurred. It's closer to a complete, total gap, as if a chunk of your own existence simply got deleted. So, what's actually happening to your mind during that missing time? Are you unconscious the entire way through, or is something considerably stranger going on? Let's dig into this properly, because the honest answer turns out to be more complicated and more scientifically fascinating than most people assume. Let's start with the most important thing to understand up front. General anesthesia isn't simply a deeper version of sleep, even though it's often casually described that way. Sleep and anesthesia involve measurably different underlying brain states, measurable and distinguishable through brain activity monitoring. And this distinction actually matters quite a bit for understanding what's really happening to your mind during a surgical procedure. During normal sleep, even in its deepest stages, your brain remains capable of being woken up relatively easily by sufficiently strong stimuli. A loud noise, someone shaking you, and brain activity continues cycling through recognizable, well-documented patterns throughout the night. Under general anesthesia, your brain enters a considerably different, more thoroughly suppressed state, one specifically designed to prevent this kind of easy arousal, since the entire point of anesthesia is to keep a patient reliably unconscious and unresponsive throughout an invasive surgical procedure, regardless of how much physical stimulation, cutting, manipulation, or pain-inducing activity might otherwise be occurring. Let's talk about what anesthesia actually does at a biological level, because understanding the basic mechanism helps make sense of everything else discussed throughout the rest of this topic. General anesthetic drugs work primarily by altering the activity of specific neurotransmitter systems throughout the brain, generally enhancing the effects of inhibitory neurotransmitters that suppress neural activity, while simultaneously interfering with excitatory neurotransmitter systems that would otherwise support normal, active brain function and communication between different brain regions. The specific combination and dosage of drugs used can vary considerably, depending on the specific procedure and the anesthesiologist's professional judgment, but the general underlying goal remains consistent, significantly disrupting the brain's normal ability to generate coordinated, integrated conscious experience while carefully maintaining the more basic essential bodily functions like breathing and heart rate that need to keep functioning throughout the procedure regardless. This detail is worth sitting with for a moment because it reveals something important about what consciousness actually seems to depend on at a biological level, a question that extends well beyond the operating room into some of the deepest unresolved questions in all of neuroscience. It's not simply about whether individual neurons are firing or not. Plenty of neural activity continues happening throughout the brain even under general anesthesia. What anesthesia specifically disrupts is the coordinated, integrated communication between different brain regions, the kind of widespread, synchronized activity that researchers studying consciousness believe is specifically necessary for unified, coherent conscious experience to actually occur in the first place. Rather than turning the brain off in any simple sense, anesthesia disrupts the specific kind of coordinated activity that consciousness itself appears to depend on. Let's talk about the different stages and depths of anesthesia, because under anesthesia isn't actually a single, uniform state, and understanding the different levels involved helps explain why the experience can occasionally be more complicated and unpredictable than people assume walking into a procedure for the first time. Anesthesiologists generally think about anesthesia across a spectrum of depth, ranging from minimal sedation, where a patient remains largely responsive and aware, through moderate and deep sedation, and finally to full general anesthesia, where a patient is completely unconscious and unresponsive to external stimuli, including surgical pain. Different procedures require different depths of anesthesia, and anesthesiologists carefully titrate the specific drugs and dosages used to maintain the appropriate depth for each particular situation, continuously monitoring the patient's physiological responses throughout the procedure to make real-time adjustments as needed. Now let's talk about one of the more unsettling and seriously important topics within this whole area of research: anesthesia awareness, a rare but well-documented phenomenon where a patient retains some degree of conscious awareness during a surgical procedure despite receiving general anesthesia, sometimes even while remaining paralyzed by muscle relaxant drugs commonly used alongside anesthesia specifically to keep the body still during surgery. This represents one of the genuine risks and ongoing concerns within the field of anesthesiology, and it's taken seriously precisely because it demonstrates that anesthesia, despite being remarkably effective in the overwhelming majority of cases, isn't always a perfectly reliable, foolproof guarantee of complete unconsciousness for every single patient in every single circumstance. Cases of anesthesia awareness vary considerably in severity, ranging from patients reporting vague, fragmentary sounds or sensations they can't fully explain afterward, to considerably more severe and distressing cases where a patient reports being fully consciously aware of pain and their surroundings during the procedure, while being completely unable to move or communicate this to the surgical team due to the paralytic drugs typically administered alongside anesthesia, specifically to prevent involuntary movement during surgery. This specific combination, conscious awareness combined with complete physical paralysis, represents one of the more deeply distressing possible medical experiences a person can go through. And it's a big part of why anesthesiologists take continuous, careful monitoring of anesthesia depth so seriously throughout every single procedure. This detail is worth including, honestly, rather than glossing over, because it reveals something important about the actual scientific and medical understanding of anesthesia more broadly. Modern anesthesia is remarkably safe and effective for the overwhelming majority of patients, and true anesthesia awareness remains statistically rare. But the fact that it can happen at all demonstrates that anesthesia works by reliably suppressing consciousness in almost all cases, rather than through some absolute, guaranteed, universally foolproof mechanism that makes conscious awareness during anesthesia completely impossible under any circumstances whatsoever. Let's talk about how researchers actually study anesthesia awareness in a controlled, scientific way, because there's a remarkably clever experimental technique worth explaining in some detail. Known as the isolated forearm technique, this method involves applying a tourniquet to a patient's arm before administering the paralytic muscle relaxant typically used alongside general anesthesia, temporarily preventing the paralytic drug from reaching that specific arm while the rest of the body remains fully paralyzed as normal. This allows a patient who might retain some degree of consciousness during the procedure to communicate that awareness by moving the hand on the isolated arm in response to a simple verbal request from the anesthesiologist, even while completely unable to move or communicate through any other part of their body. Studies using this specific technique have found that a small but measurable percentage of patients, considerably higher than the rate of confirmed, remembered anesthesia awareness cases, actually respond to verbal commands during supposedly full general anesthesia, suggesting some degree of processing and responsiveness, can persist even when a patient shows no outward signs of awareness and later has no memory of the experience whatsoever. This finding is seriously significant for the broader scientific understanding of anesthesia and consciousness, because it reveals a meaningful gap between complete unconsciousness, no responsiveness or processing of any kind, and complete conscious awareness, full alertness with lasting memory formation. The isolated forearm technique suggests there may be an intermediate zone, some capacity for processing information, and even responding to simple commands. Existing without full conscious awareness and without lasting memory, that occurs more commonly during anesthesia than previously assumed. Researchers are still working to fully understand what this intermediate zone actually represents, whether it constitutes some limited form of consciousness, a kind of automatic, non-conscious responsiveness, or something else entirely that doesn't map cleanly onto existing categories of consciousness and unconsciousness researchers have traditionally relied on. Let's talk about specific brain monitoring technology used during modern anesthesia too, because this represents an important practical development directly connected to everything already discussed regarding brain activity and consciousness. Modern anesthesiologists frequently use specialized monitoring devices that analyze a patient's brain activity in real time throughout a procedure, providing a continuously updated numerical estimate of anesthetic depth, based on specific patterns detected in the brain's electrical activity. These monitoring systems represent a direct practical application of the broader scientific understanding of which brain activity patterns correlate with different levels of consciousness, allowing anesthesiologists to make real-time adjustments to drug dosing specifically aimed at maintaining an appropriate depth of unconsciousness throughout a procedure, rather than relying purely on standardized dosing calculations or external physical signs like heart rate and blood pressure alone, which don't always reliably correlate with actual brain state and depth of unconsciousness in every single patient. By the way, if you want to go even deeper into the secret lives of ancient humans, I just launched a full course called The Secret Lives of Ancient Humans. 10 modules, 3+ hours of content covering everything we never talk about on YouTube. What they feared, how they communicated, what hunted them, and much more. Plus an exclusive PDF guide included. Link in the description. See you inside. The development and increasingly widespread adoption of this kind of real-time brain monitoring technology represents a direct, practical response to the anesthesia awareness concerns already discussed, giving anesthesiologists an additional, more direct source of information about a patient's actual brain state throughout a procedure. Beyond simply calculating an estimated dose based on body weight and assuming that dose reliably produces adequate unconsciousness in every single patient without meaningful individual variation. Let's talk about individual variation in anesthesia response more broadly too, because this represents another important, actively researched factor worth understanding. People vary considerably in exactly how much anesthetic drug is required to reliably achieve adequate unconsciousness, influenced by factors including genetics, body composition, age, certain medications a patient might already be taking, and even, according to some research, specific genetic variations affecting how individuals metabolize and respond to particular anesthetic drugs. This individual variation is a significant part of why standardized one-size-fits-all dosing approaches carry some inherent risk of occasionally underdosing a particular patient relative to their own specific physiological needs, which connects directly back to why real-time brain monitoring and careful, continuous adjustment throughout a procedure has become such an important part of modern anesthesia practice, rather than simply calculating an initial dose and administering it without further adjustment throughout the entire procedure. Let's talk briefly about local and regional anesthesia too, because it's worth distinguishing this from general anesthesia specifically, since it represents a meaningfully different category involving a very different relationship between the mind and the anesthetic process. Local and regional anesthesia, including techniques like epidurals or nerve blocks, work by specifically blocking pain signals from a particular part of the body without necessarily affecting overall consciousness at all. A patient receiving regional anesthesia for a procedure might remain fully awake and consciously aware throughout, simply without feeling pain in the specific area being operated on, representing a completely different mechanism and mind-body relationship compared to general anesthesia's much more comprehensive disruption of overall brain activity and consciousness itself. This distinction is worth appreciating because it demonstrates that modern anesthetic practice actually encompasses a fairly broad range of different techniques, each targeting a different, specific aspect of the pain and consciousness relationship, rather than representing a single, uniform approach applied identically to every single medical procedure, regardless of its specific requirements. Let's talk about memory specifically now, because this connects directly to something worth understanding clearly. And it's arguably the single most practically important part of this entire topic for anyone actually preparing to undergo a procedure themselves. Even in cases of confirmed anesthesia awareness, patients frequently don't remember the experience afterward, which might initially seem confusing until you connect it back to the broader relationship between consciousness and memory formation. Certain anesthetic drugs specifically produce strong amnesic effects, meaning they interfere heavily with memory formation, independent of whatever degree of consciousness or unconsciousness a patient might be experiencing at any given moment. This means it's theoretically possible for a patient to have some degree of conscious awareness during a procedure, without that awareness ever getting properly encoded into a lasting, retrievable memory afterward, similar in principle to the memory formation breakdown discussed regarding the ordinary transition into natural sleep, just achieved here through a considerably more powerful, deliberately engineered pharmacological mechanism rather than through the brain's own natural sleep onset process. This is actually one of the more reassuring aspects of modern anesthesia practice worth appreciating directly, because it means anesthesiologists specifically use drug combinations designed to address both unconsciousness and memory formation as separate, distinct targets, rather than assuming that simply preventing conscious awareness alone would automatically be sufficient to prevent any possibility of a patient later remembering something distressing from their procedure. Modern anesthetic protocols specifically incorporate this dual approach, targeting both consciousness suppression and memory formation disruption together, precisely because researchers and clinicians understand these represent two separate, at least partially independent brain functions that both need to be reliably addressed for a truly safe, comfortable surgical experience. Let's talk about dreaming under anesthesia too, because this represents another seriously interesting and somewhat contested area of ongoing research, one that continues to generate genuine scientific debate among specialists in the field. Some patients do report dreamlike experiences following anesthesia, though researchers remain divided regarding whether these experiences actually occurred during the deepest, most suppressed phase of anesthesia itself, or whether they occurred during the lighter stages of emergence from anesthesia, as the brain gradually transitions back toward full consciousness and begins regaining more normal, coordinated activity patterns. This distinction matters considerably because it connects to everything already discussed regarding brain activity and consciousness. During the deepest phase of properly administered general anesthesia, the specific kind of coordinated, integrated brain activity that most researchers believe is necessary for any kind of conscious experience, dreaming very much included, appears to be substantially disrupted, which would make actual dreaming during that specific deep phase considerably less likely from a purely neurological standpoint, even though it doesn't rule out our fragmentary dreamlike experiences occurring during the lighter, more variable stages of anesthesia induction or emergence. Let's talk about anesthesia emergence specifically too, because waking up from anesthesia represents its own distinct, sometimes strange transitional process worth understanding a bit better. As anesthetic drugs gradually wear off and clear from the body, patients typically pass through a somewhat disoriented, confused transitional state before returning to full, clear consciousness, sometimes involving temporary confusion, unusual emotional responses, or difficulty immediately processing where they are and what's happening around them. This emergence period reflects the brain gradually regaining its normal, coordinated activity patterns and functional connectivity between different regions, a process that doesn't happen instantly the moment anesthetic drugs stop being administered, but rather unfolds gradually over a period of minutes to sometimes considerably longer, depending on the specific drugs used, the length and nature of the procedure, and individual patient factors including age and overall health. Now let's talk about age-related differences in anesthesia experience, because this represents an important, actively researched area worth mentioning specifically, one with real practical implications for how anesthesiologists approach very young and very old patients differently. Older patients and very young children sometimes experience more pronounced confusion or temporary cognitive disturbance following anesthesia compared to healthy young and middle-aged adults, a phenomenon researchers refer to using terms like postoperative delirium or postoperative cognitive dysfunction. Researchers are still actively working to fully understand exactly why certain populations appear more vulnerable to these temporary post-anesthesia cognitive effects, though current research points toward a combination of factors including age-related differences in brain resilience and recovery capacity, along with the specific type, duration, and intensity of anesthesia and surgery involved in each particular case. Let's talk about a remarkably fascinating research angle worth mentioning here too, involving what anesthesia has actually taught neuroscientists more broadly about consciousness itself, well beyond its practical medical applications. Because anesthesia offers researchers a rare, controllable, reversible way to systematically suppress and then restore consciousness in a laboratory or clinical setting. Studying the specific brain activity changes that occur as someone transitions into and then back out of anesthesia has become an incredibly valuable tool for consciousness researchers more broadly, offering insights that are considerably harder to obtain through almost any other research method. by carefully tracking exactly which specific patterns of brain activity disappear as a patient loses consciousness under anesthesia, and which patterns specifically return as consciousness is restored during emergence, researchers have been able to develop increasingly sophisticated theories about which particular kinds of brain activity and connectivity patterns are actually necessary for conscious experience to occur at all. Insights that extend well beyond anesthesia itself into broader neuroscience and philosophy of mind research more generally. This represents one of the more unexpectedly productive intersections between medical practice and fundamental scientific research worth appreciating because anesthesia was developed purely for practical medical purposes, allowing surgery to be performed without patients experiencing unbearable pain, rather than as any kind of deliberate research tool for studying consciousness. But the specific way anesthesia reliably and reversibly suppresses consciousness has turned it into one of the most valuable, practically accessible research tools available for studying one of the most difficult and fundamental questions in all of neuroscience: what consciousness actually is, and what specific brain activity it actually depends on. It's worth acknowledging directly, before wrapping up, that some seriously difficult philosophical questions remain unresolved within this entire area of research, and honest scientific communication about anesthesia and consciousness should reflect that ongoing uncertainty rather than presenting a falsely complete picture. Researchers still don't have a fully settled, universally agreed upon theory explaining exactly why certain patterns of brain activity produce conscious experience while others don't, which means anesthesia research, however valuable and clinically important, is still contributing pieces to a much larger, still unfinished scientific puzzle regarding the fundamental nature of consciousness itself, rather than having already delivered a complete, final answer to that deeper question. Let's zoom out and pull all of these different threads together, because the full picture of what happens to your mind under anesthesia turns out to be considerably more nuanced and scientifically significant than the simple, common assumption of "you're just very deeply asleep" would suggest. Anesthesia works by disrupting the coordinated, integrated brain activity that consciousness appears to depend on, achieving a measurably distinct brain state from ordinary sleep. One specifically engineered to reliably prevent both conscious awareness and, through separate pharmacological mechanisms, the formation of lasting memories, even in the rare cases where some degree of awareness does occur. This dual mechanism, addressing consciousness suppression and memory disruption as separate targets, reflects a sophisticated, deliberately engineered medical practice built on an increasingly detailed scientific understanding of how these two related but meaningfully distinct brain functions actually work. So the next time you go under general anesthesia for a procedure and experience that strange, complete gap where hours simply vanish without a trace, it's worth appreciating that you're not simply having an unusually deep sleep. You're experiencing a carefully engineered, medically controlled disruption of the very brain processes that generate consciousness itself, a state so distinct from ordinary sleep that studying it has become one of neuroscience's most valuable windows into understanding what consciousness actually is in the first place, and what it takes at a biological level to switch it off and safely bring it back again. It's worth adding one final practical note here too, because it grounds this entire discussion back in something directly relevant to anyone facing an upcoming procedure. Patients who have specific concerns about anesthesia awareness or memory of a procedure can and generally should discuss those concerns directly with their anesthesiologist beforehand, since modern anesthesia practice increasingly incorporates individualized monitoring and dosing precisely to address the kind of person-to-person variation already discussed throughout this topic, rather than relying purely on generic standardized protocols applied identically to every single patient regardless of their own specific physiology or concerns. Which leaves an interesting thought worth sitting with. If modern medicine can reliably and reversibly switch off something as fundamental as human consciousness, precisely enough to perform invasive surgery without a person experiencing any of it, what does that suggest about how physical and mechanistic consciousness itself actually is, however mysterious and unified it might feel from the inside during every single ordinary waking moment of your life, and however far science still has to go before it can fully explain why that switch works at all?